All right, good morning or good afternoon, everybody. Thank you for joining our best practice brief presented by South Dakota Foundation for Medical Care. So the best practice briefs are a partnership initiative of the South Dakota Foundation for Medical Care and the Great Plains Quality Innovation Network. My name is Vicki Palmreiter, and I have the pleasure of working for South Dakota Foundation for Medical Care and serving as tribal liaison and program assistant for the Community Health Worker Collaborative of South Dakota. I am in place of our colleague Stacy Fredenberg, who serves as the South Dakota Community Coalition lead for the Great Plains Quinn. She was not able to join us today, so I am taking her place to help with this best practice brief today. Before we begin, there are a few housekeeping items to review. Today's session is being recorded and will be posted at sdfmc.org on the best practice briefs page. All lines will be muted throughout the presentation. Please add any comments or questions to the chat and they will be addressed at the end of the presentation today. This presentation is part of a larger series that is exploring strategies for encouraging proper use of emergency departments. And while most individuals work to avoid the emergency department, others consider it a source of primary health care. And of course, when emergency services are overused, the cost of healthcare increases across the board. Today's speaker, Alyssa Olson, will focus on relieving healthcare concerns by creating connections. So she's going to talk about community health workers. Community health workers are really rising to the top of the list of who to know in South Dakota communities. CHWs help individuals locate community resources and navigate the healthcare system. Creating connections relieves pressures from individuals and healthcare professionals. So Alyssa from Brookings Health System will share the benefits of incorporating CHWs for improving health and quality of life. Alyssa, thanks for sharing with us today. You can begin your presentation now.
Hello, everyone. I'm going to go ahead and share my screen so you can see my PowerPoint. And thank you for that introduction and the opportunity to share today. Can everyone see my PowerPoint?
Yes, looks great.
All right. This was already briefly touched on, but I wanted to start with just kind of an overview of what a community health worker is, since it's so new in the state of South Dakota. Community health workers, otherwise referred to as CHWs, are frontline public health workers. They're a trusted community member. They typically share some of the same life experiences as the patients they're working with. They're dedicated to building relationships and connecting with others. They link patients to healthcare services, social services, and community resources. They also act as a patient advocate and accountability partner. In early August 2021, Brookings Health System received a health disparities grant in order to begin the process of starting a CHW program. I completed my certification at Lake Area Tech in Watertown in December 2021, and we began program development in January 2022. The program launched in March of that same year, and I started to see patients. This is just a little information about our program before I start getting into some of the specific objectives. Our overall goal with this program was to improve patient outcomes by reducing readmission rates. For us, that meant keeping inpatient units out for more than 30 days and ED utilizers out of the emergency department for at least 72 hours. The target populations I started to work with were frequent emergency department utilizers and inpatients who are at high risk of readmission. Referrals typically come from the providing physician, but they can be initiated by case managers and nurses. I typically do a consult with patients prior to hospital discharge whenever possible to make that initial connection with them. They are more likely to follow through with the program if they have a face to put with the name, and I've been able to meet them before they go home from the hospital. And then I follow up with 3 different types of visits after they leave the hospital. Whenever possible, I do home visits. It is a better way to connect face-to-face with the patient, gives me more of a holistic view of the patient and their situation and circumstances. If home visits are not possible, I am able to do phone visits, or sometimes I'll meet with patients here at the hospital. That could be for a couple different reasons. Sometimes patients are not ready to jump into home visits with someone they barely know, or occasionally there's a situation where it's not safe for me to go to their home. The majority of our referrals come from the inpatient unit at the hospital, with a smaller portion coming from the emergency department. And as you can see on this slide, there are also a small amount of clinic referrals there. We just started accepting clinic referrals this past month, so we do expect this referral source to grow. We have seen some differences in our readmission rates. Out of the 48 inpatients whose 30-day goal has already passed, only 4 of them were readmitted within that 30 days. Of those emergency department patients in the program, there was only 1 that had 2 separate readmission instances in under 72 hours while part of the program. I work with a wide age range. As you can see here, my youngest referral is 6 months old and my oldest 94 years old. The majority of patients do end up being between about 40 and 70 years of age, kind of that age range when all those chronic health conditions start setting in or catching up with patients. But I do have a significant number of patients that are younger and older than that. So the objectives of today's presentation are to explain how community health workers support the proper use of healthcare services, describe the process for integrating a CHW into a healthcare system, and then identify ways to use CHWs to relieve workforce demands. In order to explain how CHWs support the proper use of healthcare services, I think it's important to discuss some of the reasons healthcare services are being misused. In my experience with patients since being a CHW, I've seen 4 common reasons behind the misuse of healthcare services: lack of overall knowledge and understanding, fear of being denied care, undiagnosed or mismanaged mental health conditions, and loneliness. The lack of overall knowledge and understanding can be addressed by CHWs through providing education to patients. Many patients simply do not understand the difference between different levels of care and when to utilize each. For example, the emergency department versus urgent care versus primary care. These patients require education on what constitutes a true emergency and when to go to the emergency department and what does not. CHWs can also provide education to patients on why chronic conditions are better addressed in primary care. I've had several patients ask me why they should seek care from a PCP at a clinic when they can simply just go to the emergency department for care. For these patients, I provide education and explain to them the benefits of building a relationship with and seeing a consistent provider for those chronic conditions. And I explain to them why this tends to lead to better health management and treatment. There's other patients who know they should be seeking primary care from a PCP at a clinic, but they don't know how to establish care with a PCP. CHWs in these situations are able to help facilitate this by providing the patient with local options, scheduling that initial appointment for them, assisting them with preliminary paperwork, etc. Patients' fear of being denied care can have several causes. Sometimes they might be in the country illegally. Other times, maybe it's because they don't have insurance or they're just not able to pay for services. It is generally well known that you will never be denied services from an emergency department. Therefore, some of these patients just seek all of their care from the emergency department. Education, of course, is key to the solution in this situation as well. However, CHWs are also able to give some more tangible assistance in these situations. I help a lot of patients apply for health insurance or sliding rates at certain clinics and or financial assistance at different locations. As a CHW, I also act as a liaison between patients and billing departments in order to help assist setting up payment plans and get needed documents and answer questions that way. All of this, of course, is in conjunction with assisting them in establishing with a PCP at a clinic, which helps get them out of the emergency department and into an appropriate level of care. Mental health can also greatly affect physical health. And so when patients are undiagnosed or mismanaging their mental health, they can easily misuse healthcare services. These concerns can be addressed by CHWs through assisting patients in overcoming the stigma of initially seeking help for their mental health. CHWs can, of course, do this through education, and then also building a trusting relationship with the patient is always important. CHWs can also make behavioral health referrals, and we do a lot of suggesting of support groups to different patients. I also many times act as a liaison or a go-between the patient and their PCP, if they have one, to request a mental health check-in or medication checkup. All of this helps facilitate continuity of care. As a CHW, I've also ended up being an accountability partner to patients regarding their treatment plan. Consistent medication compliance is something that I assist patients with often. I help them set up a daily routine, implement tips and tricks on how to stay consistent with medication, which is very important to mental health. And then I also do a lot of encouraging of using healthy coping strategies and skills. Sometimes the most complex patients are those who are seeking healthcare services solely due to loneliness. They might feel comfortable, cared for, and understood in a healthcare setting, and therefore overuse the services in order to not feel alone. In these situations, I address this by making referrals to companion services and support groups. As a CHW, I also help facilitate community involvement by providing these patients with up-to-date community events and really give them opportunities to create connections with others in the community. Overall, these patients really benefit from just assistance in creating and building a strong social support network. If patients are able to find purpose, community, and companionship outside of the healthcare setting, their misuse of healthcare services declines. We're going to talk a little bit about integrating a CHW into a healthcare system. Developing a plan with organization leadership, which establishes program goals and a framework for the program, is one of the first steps of implementation. This should be closely followed by identifying key benchmarks to monitor program successes and growth. The job description and duties of the CHW should be clearly outlined, as well as defining the role the CHW will have with different service lines, meaning how will the CHW work with home health services and occupational therapy that maybe is going into these patients' homes. Educating staff, as well as focusing on facilitating opportunities for the CHW to meet healthcare providers, share about the program, and build connections is also crucial to integrating a CHW into an already established healthcare system. It is helpful to network with other programs to gain insight on how implementation looked for them versus how their program is currently functioning. Allowing for mistakes and opportunities to reevaluate and adjust the program and processes accordingly. Always be willing to ask questions and stay active in learning about all of the community resources. Lastly, staying engaged statewide and just continuing to network with others is very important. Tying back into our first objective, CHWs help relieve workforce demands by facilitating proper use of healthcare services. Lowering readmission rates to the hospital and reducing ED visits greatly relieves the burden on healthcare facilities. The last one of this list refers to social determinants of health, which I would like to spend just a little more time discussing. This is a really great visual that shows that 80% of what makes up someone's health is actually determined by what happens outside of the hospital and healthcare setting. CHW work really focuses on getting to know that 80% of the person, which can include relationship and trust building, conducting a needs assessment, determining what resources may be beneficial to the patient, making appropriate referrals, really working on setting obtainable goals towards a bigger goal with patients, and then tracking progress with them, and providing continued social support throughout the whole process. Some of the most common needs I address as a CHW include things like basic household items, furniture, more specifically beds for patients that are maybe sleeping on the floor, transportation needs, general social support and accountability. I've worked with a lot of patients on their communication skills, more specifically how to communicate with healthcare professionals, teaching them how to schedule their own appointments, teaching them how to act at appointments, how to bring up their questions to their provider. All of those kinds of things, people can really benefit from coaching. Overall lifestyle coaching. I do some referrals to health insurance and financial assistance applications, and then there's also a large need for food resources. As you probably know, many of these things are not part of the job duties of healthcare providers, but these things greatly impact people's health and well-being. By taking on the responsibility of assisting patients with these social determinants of health, it helps relieve the workload on other healthcare providers, allowing them to focus on their more medically specific job duties. We're going to walk through a quick case study here just to kind of give you an example of what type of a patient is referred to the program, and then kind of what the CHW intervention would look like and the results seen from it. This particular patient was a middle-aged female living alone. Husband had recently passed away. There were multiple chronic health conditions. She was non-compliant with her medications, had a long history of not showing up to follow-up visits, adamantly did not want people in her home. Later, we had found out that she struggled with hoarding, which was the main drive behind not wanting people in her home, and she had a long history of refusing services offered. More specifically, it had been about 2 years of refusing services offered to her by the clinic and hospital. This patient started out with an ED referral being sent to me because they had multiple frequent ED visits. One of those ended up in admission to the hospital. So then I also received a referral for this patient from the inpatient unit due to failure to thrive. This patient was a little bit tricky to connect with. I really work on trying to keep patients from slipping through the cracks. And sometimes they can be really difficult to connect with when they're in and out of the ED often, because lots of times ED visits don't align with a regular day of work. So for this specific patient, when they ended up admitted to the hospital, I went and met with her prior to discharge and just spent some extra time with her to try to prevent that slipping through the cracks. As you can see here, I noted that part of my intervention was an extended consult prior to her discharge. With this patient, I really focused on building rapport and trust. During this hospital stay, this patient had admitted to the hoarding issue that she had. So I really made sure that I encouraged her and recognized how huge of a step that was for her to admit that. Really focused on breaking down some different barriers with her by connecting on a deep personal level. Kind of depends on the situation. You need to feel each one out separately, but in this situation, it really was beneficial to share some of my own personal experience to really help relate with her. It all comes back down to, building that connection with that patient. We really worked through acknowledging and discussing some of the feelings that she was having, like shame, guilt, and fear. And then throughout this entire consult, I never mentioned that the goal of the community health worker program was to do home visits and assist patients that way. Because I knew if I led with that, she would most likely immediately turn it down. So at the end of the consult, I had brought up the idea of maybe letting me come for a home visit. And after some convincing, she did agree to that, which was a really, really big step for her. I also made sure I reinforced the benefit of accepting the skilled home health services that were being offered to her, and later found out that following our visit, she accepted all of the services that had been offered to her that she had been turning down for a couple years. My main role in this patient was creating that connection and really breaking down those initial barriers to get her to accept services. So with collaboration from physical therapy, occupational therapy, home health, there was some family involvement, and myself, the patient, is now regularly taking medications, checking blood sugar, went back to seeing their mental health counselor regularly, attending all follow-up doctor appointments, is getting assistance with cleaning their home, now wearing clean clothes. Plumbing has been fixed in the home, so they're able to independently take showers and baths. Emergency response system has been set up. Regular meals are being delivered, and the patient has started driving again. This person saw a significant increase in overall health and well-being and a significant decrease in ED visits. As of December, the patient had not been back to the ED since CHW program intervention and services in the home, and was only hospitalized once. And that concludes my presentation, and I think we're going to maybe move into some questions.
Yes, thank you for sharing with us today, Alyssa, not only your best practices, but hearing that awesome success story at the end. So we'll use any remaining time for questions. If you have a question, you can go ahead and type it into the chat box, or you can unmute yourself and verbally ask a question of Alyssa. Also, while you're thinking of your questions, there is a link to a survey to complete an evaluation of today's best practice brief. So we encourage you to do that before you leave. And I don't see any questions coming up now, but I have a question for you, Alyssa. Can you tell us just a little bit more about the referral process? And it might be different depending on if it's inpatient or clinical. I know you're just starting to work with the clinic now, but can you tell us a little bit about what that was like to get set up and kind of how that process works without, I guess, getting too far into the weeds with the technology? Do you use your EMR for that, or and then also kind of a second part to that is what did you do to talk about the program to providers who could potentially be referring to you?
Yeah, those are great questions. The referral process is built into our EMR. So there is a place that an order can be sent, and then we have it set up so that it will just print out on the printer in my office. And that's from both the emergency department and the inpatient unit. The clinic, the referrals were coming over just as a paper form initially, but we're now getting it set up so that they can enter an order online through the EMR, because we do share the same EMR, with that clinic. So that's how we're handling the referral process. And then I believe you asked kind of how I shared about the program with potential referring physicians. I really got a lot of support from upper management here at the hospital. So they were able to facilitate inviting me to provider monthly meetings, get-togethers, lunches, board meetings, I was really able to share at a lot of different things going on at the hospital that were already taking place. And I would just kind of take like a 10-minute chunk out of it to share about the program, because really it's just one of the most important parts of implementing something new into an already established program, healthcare system and program, is getting the word out there so that people understand what it is and they know it's available, and really getting a few people kind of on your side to start making those referrals. And then once you kind of do that, the word really does start to spread and people start to realize the benefit of it. And then more and more people start making referrals.
Wonderful. Yeah, I think that as you start to explain how you can assist with those patients that might be presenting with more of the social determinants of health needs, that maybe the clinical staff don't necessarily have the expertise or the time to help the patient with, the value is really becomes clear to the providers then, oh, Alyssa can help with this. And I think what you've done, it has just been a great example of how to integrate in with the providers, and they are thinking of you now as they have patients present with those social determinants of health needs especially. So thank you again for sharing. I don't see any other questions, and it looks like we're about at the end of our time here today. Rhonda said no questions, but thank you for a wonderful presentation. So as we close out, please take a moment to complete the evaluation using the link in the chat box. And if you have a request for a best practice brief topic, or if you have a best practice to share, you can go ahead and reach out to Stacy. I'll have Stephanie put Stacy's contact info in the chat as well. And thank you again, Alyssa, for sharing a little bit more about what you do today. We appreciate all of you for joining today. And thanks, and have a wonderful day, a great week.
Thank you for having me.
You bet. Bye-bye.